Hi everyone, this is Drew Heinmiller here from Fujifilm VisualSonics. Thank you for attending the webinar. Apologies for starting a couple of minutes late, but we're really excited today. Today we've got Jessica Freeling talking about the assessment of murine colorectal cancer by ultrasound. So we're really excited to hear her speak about that. A few things we want to cover just before beginning the webinar. First of all, we're recording this webinar right now, so it will become available when we finish. Right now, all your lines are muted, and they will remain muted for the duration of the webinar. If you have any comments or questions or anything, please use the chat window. And throughout, please feel free to post your questions in the chat window, and we'll be sure to ask Jessica those questions at the end of the webinar. As I mentioned, we will be answering those questions at the end. So we're talking about probably around 45 minutes here, with some time at the end for questions. Now I'd like to introduce Jessica. Jessica Freeling is the manager of the physiology core at University of South Dakota's Department of Basic Biomedical Sciences. She's been working in animal research for a long time, 15 years, doing both large and small animal models. And she does surgical and imaging services for cardiovascular, neuro, and cancer applications. Today she's going to be talking about a collaboration with Dr. Khosrow Rizvani, and they've developed a new method for looking at non-invasive longitudinal imaging of colorectal cancer in mice using the Vivo 2100 ultra-high frequency ultrasound system. So without further delay, I'd like to hand things over to Jessica.
Okay, so today I'm going to talk about a way to assess murine colorectal cancer using ultrasound. And we're going to do that in 3 dimensions and also look at vascularity using nonlinear contrast imaging. So here, just a brief outline. I'm going to first show you a background on colorectal cancer. Then we'll talk about some common colorectal cancer mouse models and how those are applied currently. And then we'll look at some current imaging modalities and limitations of those modalities. We're going to look at traditional evaluation, how we typically look at colorectal cancer if we don't have imaging ability, and what would be ideal. And we're going to propose then a technique using 3D reconstruction as a supplement to traditional evaluations. And so we'll present a case study, and we'll talk about how to use microbubbles to do relative vascularity. And like any imaging modality, there are always artifacts and limitations, so I'll talk about those at the end. So just briefly, let's talk a little bit about colorectal cancer. Over 100,000 individuals are diagnosed each year, and about 50,000 die in the United States. And it's a major cause of cancer deaths worldwide, with a lifetime risk of around 5%. About 50% of colorectal cancer patients develop recurrent disease, and unfortunately the overall survival rate is just 6 to 12%. This slide highlights a really recent article that was in the New York Times, and it talked about a young woman named Kristen who is exactly my age, and unfortunately she died last month of colorectal cancer. This slide just highlights that we really don't understand this disease, and the reason for that is that in the young population since about 1980, we've seen a dramatic increase in the incidence of colorectal cancer. While the incidence is clearly higher in the older population, we've seen a decline in the incidence in that population. So it just highlights the importance for understanding this disease, and it's possible that the mechanism is completely different in the young versus the old. So let's just think about translationally what we need to be able to see when we're imaging these mice. Just like the human, colorectal cancer has multiple stages, and each of those stages have an increased invasion into the colon wall, and also an increase in the vessels that are able to feed these tumors. So the tumors actually are able to recruit these vessels. And in the later stages, we see necrosis of the centers of these tumors. And this will become important later on, and I'll bring that up again. And so our major challenge is development of novel targets for therapy. And to be able to do that, we need a good animal model, and we need a good way to assess that model, and that's where imaging comes into play. So let's look quickly at some common colorectal cancer mouse models, and one of the most common that's been used in a lot of different kinds of cancers, in fact, is the xenograft model. In the xenograft model, cells are injected subcutaneously. However, those cells are not living in their proper physiologic environment, and so then some researchers turn to an orthotopic model in which cancerous tissue is surgically implanted onto the colon wall or even onto the cecum itself. But this model is surgically invasive, and so we might have inflammation that's due to the surgery and not to the cancer itself. So in about the last decade or so, most researchers have turned to an inducible colorectal cancer model in which a carcinogen called AOM and an inflammatory drug called DSS is delivered systemically to induce disease. And the nice thing about this is we can recapitulate that colorectal cancer microenvironment, including growth and metabolism of those tumors. And the additional advantage is that we can then genetically manipulate those animals and combine that with the AOM DSS inducible model. So let's just look quickly at what potential imaging modalities are currently available. Believe it or not, you can do a colonoscopy in a mouse. Unfortunately, the systems to be able to do that are not very widely available. In fact, most of the colonoscopy scopes that have been made are being made by the labs themselves. This is limited somewhat because we can only see from the inside of the colon. We're only seeing in a two-dimensional image, for example. And we can't find out anything about total tumor load very easily. MRI and CT would allow us to look at total tumor load, for example, but it's just a snapshot. So we can't see, we can do longitudinally, but we're not seeing in vivo real-time what's happening in that colon. And as we all know, MRI and CT are quite expensive, and a lot of research institutions such as us just don't have access to it. Other modalities that are available, such as biomicroscopy and ultrasound, two-dimensional ultrasound are available. Again, though, we're just looking at two-dimensional images, and so that doesn't tell us much about what's happening with that cancer as a whole. And some of these models or methods are not necessarily longitudinal or can't be repeated because of limitations in survival. And so the final thing I want to point out is that none of them offer real-time vascular data, and I propose that with this imaging modality that we can do that. So we need to know traditionally what researchers are doing that don't have access to imaging, and the data is good, but it's somewhat limited in richness. And so what we do currently is we just at termination, we're taking two-dimensional pictures, and then we can use those two-dimensional images to just generate total surface area of tumor as a ratio to colon, for example, or we can do colon length and weight. We can do scale-based scoring systems, so we can say, well, this upper image, the colon is a grade 5, for example, and this is a grade 2, but that's somewhat subjective. But typically we're just doing this at termination and it's not longitudinal. To make it longitudinal, we then have to use more animals and take animals at more time points, which is not always feasible. And again, we have no information about vascularity from these images. And so what we're proposing is a way to be able to longitudinally assess that same animal and see those changes in those tumors as we go along. So why do I have a picture of all this South Dakota blue sky here? And it was just to remind me to tell you that, oops, in an ideal world, whoops, let's go back here. In an ideal world, what would we need to evaluate colorectal cancer? So this is my ideal world. This is where I escape to on the weekends. We would definitely need a resolution that's powerful enough for a small-sized animal model. Clearly the mouse is very small. In fact, the colon is approximately a 30th the size of the human. And so we need something very powerful to be able to do that. We need something non-invasive and longitudinal, repeatable with minimal training. And it would sure be great if we could get tumor load, total tumor volume, rather than just those areas that I showed you in the previous picture. And it would be even better if we could look at vascularity to find out what's actually happening in vivo to these animals. And obviously all of these things would decrease animal use, which is important for me. I'm a vet tech, so I think it's very important to try to reduce animal use. And we need to be able to match and to create drugs and therapies that match or that are translatable to humans. We need strong statistical power, so we need richer data than what we have now. So we're proposing using this 3D micro-ultrasound system, or the VisualSonic Sweevo 2100 to do 3D micro-ultrasound. This system is more widely available to researchers than any other non-invasive in vivo imaging modality. And Stephen Butters at VisualSonics tells me that at least one of these units is in 90 of the top 100 NIH institutions. And we have this, this unit, even though we have only about 20 researchers at any given time that are doing animal research, but we have this system because we use it widely for echocardiogram, for cardiovascular research, and then we just extended its use to cancer. And so here's a close-up of what we're going to do. So you can see this silly little rubber mouse laying here. Typically its paws would be taped to these gold pads here so we can monitor respiratory and heart rate. And this is a heated stage, by the way. This is the probe that we're going to be using for doing the actual imaging. And what we do is we attach it to a 3D motor. And this 3D motor is controlled by the computer. And so what it can do is take incremental small or individual pictures, and then it can compile those into a 3D. So almost like a Z-stack is done with a confocal microscope, for example. And you can see, and this will become important later, you can see the liberal amount of gel that's applied externally, and I'll explain why that's so necessary. Okay, so to be able to image these animals, we need to know a little bit about their anatomy. It is quite different than the human colon anatomy. The human colon anatomy takes a lot of twists and turns. And luckily, in the mouse, we have a pretty straight shot from the anal end upwards. And so, but again, the colon is very small. So our imaging window, or that we take with the 3D reconstruction, is approximately 35 millimeters long, and the colon itself is only about 5 millimeters wide. But what we found is the excellent resolution of this system enabled us to image these very small colons. I just want to point out one more thing that's important for the anatomy on these animals. When we image, we're going to just be imaging the mid and distal colon. In our model, we found that the tumors mostly appeared in the mid and distal colon, so this worked out quite well. That's not to say that we can't image the proximal colon, but we just decided, just because the 3D motor's maximal imaging window is 35 millimeters, it just worked out beautifully. So we were able to image up to about 35-gram mice without any problem. And there's also two things that I want to point out about imaging. We can very clearly see the anatomy of the anus and also that flexure. As we're going through the images, and this will make more sense when I show the next slide, but we can actually see that flexure approaching in our video of recording those image slices. And we can use that so that we can compare animals, because we have a landmark for imaging the end, the top and the bottom of that colon section. So I'm going to hope this plays here. So this is a video of real-time acquisition starting at the anal end of the animal going up towards that flexure I spoke of. And so I'll point out some tumors and so forth here as they go by. And what you'll notice is that we can very clearly even see quite small tumors. Here's one here, here's one here. And we can see that wall, so we can even measure how thick that wall is. And here's a big tumor coming right here. In a second, there's going to be a tumor coming, that's the bladder, by the way, right here. We're going to see a tumor coming that's so large it almost completely blocks the colon. And so that'll be appearing here in just a minute. So you can see how clear this image is, and that's really exciting. There's a giant tumor coming up right there. So how does this work? Then we take each of those individual images, so that looked like a video, but it was really 344 individual images that were captured. We then go frame by frame and define the wall and the tumors, and this is done by the user. And so once you define those, then the software can generate volumes for individual tumors, and then it's exportable to Excel, so you can get the total tumor load of an individual animal. And so we can see that especially if you take the time to do the outer and inner walls, we can also subtract those values and get a volume for the colon as well, which is indicative of inflammation. So I'm just going to go through the steps. So there was definitely some tricks to making this work. So if you just put an ultrasound probe on the animal of on the abdomen of an animal with external gel, really you can't see much. And the reason for that is you just cannot see the lumen of that colon. And so what we needed to do, and this was the main trick, was to introduce gel retrograde into the colon itself. And that's what delivers that great contrast between the lumen of the colon and the rest of the abdomen. So let's just kind of go through the steps. This slide would actually be, if you wanted to try to this imaging modality, I would just print this slide off. It pretty much has everything that you need to know to be able to perform this. So basically we needed to fast animals overnight. 16 to 18 hours worked well, and that's just to remove the excess feces from that colon. We used light isoflurane anesthesia. As I'll talk about, we're going to look at some vascular parameters of these colons, so I emphasize light anesthesia. We don't want to inhibit cardiovascular function to therefore affect vascular function of the colon. Okay, and then we took and we used Nair depilatory cream and removed the hair from the whole abdomen, and take care to remove hair around the anus. A lot of these tumors appear right around the anus. If you make sure that you remove that hair, then the tumors are very clearly visible. And then we do a generous application of external ultrasound gel, again building up that Nair or the gel around the anus so we can image that clearly. Anybody that does ultrasound knows that air bubbles are not our friend. We went so far as to sometimes centrifuge our ultrasound gel. We gave atropine to halt peristalsis in these animals. So we used a short-acting form of atropine that dissipated in just 10 to 15 minutes, but it gave us enough of a pause in that peristalsis that we could prevent the expulsion of that intracolon gel that I alluded to. And so that was the next thing that we did, was we delivered ultrasound gel retrograde into the colon. And ultrasound gel is inert, it's water soluble. We just loaded a 10 milliliter syringe and centrifuged it to get rid of any bubbles, and put a needle on there with a piece of PE60 tubing threaded onto the needle because we don't want to poke anything. And we used that to introduce retrograde into the lumen of the colon. And I'm just going to go back through these steps to kind of put it all together. So we'll fast the animals, put them under anesthesia near the abdomen, put the external ultrasound gel on, kind of line up your image as best you can because you still can't see anything in there until that lumen gel is applied. We would administer the atropine to stop peristalsis. Before that atropine took effect, we would then go in and insert that gel into the lumen, and what that would do is push out any remaining feces. By the time then you got the image set up, you got your 3D parameters entered and so forth into the software. By that time, the atropine had kicked in. If there were any remaining feces in that colon at that point, we then introduced the gel into the colon again and pushed any feces up and around that flexure that I discussed. And so if you do all of these things, you can get beautiful images. And I know it sounds like there's a lot of steps and details, but if you do the tricks that we've already worked out, it works very nicely. So here's an example of the graphical renderings that this amazing software does. So basically you go frame by frame, as I pointed out, and by the way, you don't have to do all 344 frames. The software is able to connect from one frame to the subsequent one that you define the borders, so it sort of extrapolates. And so you can go frame by frame and define all of your tumors, define your colon walls, which you can see here are very clearly, especially in this sagittal plane image. You can see how perfectly it follows this colon wall, and then you can see those tumors. And then it gives you a beautiful, actually this is just a 2D version or picture of the 3D image. I'll show you in just a second what the construction looks like with it spinning around. But the anal end here is at the left, and then that flexure is here on the right. And that entire imaging window encompasses about 35 millimeters. And we can actually also measure colon length, which is important because these animals typically with heavy loads of colorectal cancer, their colons actually shrink. And so we can actually image that because, measure that because we have the landmarks of the anal end and when that flexure is approaching to be able to get the length of the colon as well. So here is the 3D reconstruction, which I am just amazed by every time I play it. So you can see how clearly those tumors appear. We can see every individual tiny tumor, and we can see the walls as well. And I wanted to just point out one thing. See if I can get it to show here. There's one particular tumor that looks like it's completely right here. It looks to be invading completely through the colon wall, which I think is really just showing the power of this and the excellent resolution of this modality. We're proposing that's actually invasion, as we're seeing with later stages of colorectal cancer, which is really great. If we can get to the level where we can see that invasion happening, we have a really spectacular imaging modality. So as a researcher, I would want to see, so it looks pretty, but can you see a difference in animals that are treated or untreated? So here's just an example of wild type animals that were given vehicle versus treatment on the left and right respectively. And so these were animals that were induced for colorectal cancer using AOM DSS. We did a pre-treatment ultrasound and then did 2 subsequent ultrasounds, one and the final one at terminations. So here's our pre-treatment differences here and post-treatment and then at termination. And so you can see that longitudinally this is just beautiful. We can get great data. We've got volumes for each of these. And then the other thing is that's so powerful, I think, is to look at termination. And so this is the same animal on the same day. So we reconstructed this animal before necropsy, and you can see how closely and beautifully these big tumors match, especially, and even these small ones match the image that we were able to collect at termination. So I've hinted at vascularity multiple times, and this part was sort of an add-on to our study, and it turned out to just work beautifully. So we used microbubbles. We used a company called Advanced Microbubbles out of Colorado. And microbubbles that are used for ultrasound imaging are just a lipid monolayer, and inside of each of those bubbles is a perfluorocarbon core. And basically those bubbles just oscillate at a frequency that the ultrasound can hear, and then it interprets it into an image. And so these bubbles are inert. We can put them in IV and have them circulate for 10 to 15 minutes, and then they just dissipate. And so they have great application for longitudinal imaging. All of our mice were injected with the same concentration and volume, and from this we can get both 2-dimensional and 3-dimensional data. So I just want to briefly talk about injection techniques. So we decided in our study to just do the microbubble injections at termination. So we wanted to ensure patent access and consistent delivery rate. And so we just surgically placed a jugular catheter, and so we didn't do longitudinal microbubble delivery, but it's definitely possible. And so I wanted to mention 2 ways that that is typically done. So tail vein injections are commonly done, and this would enable a longitudinal study. It proved a bit difficult in our model. And I also want to point out retroorbital injections. So we've been recently playing with doing this in brain imaging, and it works beautifully because in brain imaging the mouse is facing us just as this picture shows, and we can access the eye and inject into that retroorbital sinus very easily. But in colon imaging, the animal is on its back with its head faced away from you. So I don't know how applicable this is, but these are both options for longitudinal vein access to be able to look at the vascularity longitudinally in these animals. So here's just a video. So those bubbles are injected IV, so I want to play a video here at about frame 75, so right in this region. Those bubbles are going to come in to the colon, so this is a sagittal section of the colon here. And you can see how beautifully it lights up all of that vasculature along the colon walls and how beautifully it lights up this tumor as well. And then this image is just what's called a maximum intensity persistence, and so we're just looking at all of those. As the microbubbles come in, each layer is just laid on top of each other, so they're persisting, so it just really gives you a clear picture of what, how well these microbubbles can enhance the contrast to be able to see the vascularity. And so as those bubbles are coming in, we can get some two-dimensional information. So we're in the sagittal plane. So we can only get 2 dimensions as these bubbles are coming in because they come in very rapidly, so we can't do that portion of it in 3 dimensions. But what we can do is we can look at the kinetics of how those bubbles are coming in, and it creates these curves, these kinetics curves. And you might look at this and just say, well, they're all the same, doesn't mean anything. Look at the scales here. Note the y-axis scales are dramatically different in a small, moderate, and heavy tumor load. And so what the software then can do is it can find out how it can determine the slope of this, which is indicative of relative blood perfusion, and then at what point do those microbubbles plateau that can give us the relative blood volume. And so let's look at that a little bit more closely. I know there's a lot of parts to this slide, but we're looking at small and moderate and heavy tumor loads, and this is pre-injection here at the top. In panel B, we have post-injection, so while those bubbles are circulating, and then in panel C, we have those that persistence mode showing, so you can see more clearly the tumor burden in each of these animals. And then what we do is we're able to then define the region of interest. So we just define that sagittal section of the colon, and then the software can determine peak enhancement. So again, that plateau of that kinetics, as I showed in the previous slide. And then we can also get the wash-in rate, which is indicative of relative blood perfusion by looking at that slope. So this is very clean data, excuse me, that we can get from each of these, and you can see that the data matches very nicely of what you would expect for small, moderate, and heavy tumor load animals. So now we have some really nice quantitative data for the vascularity of these colons. And so this is just some blown up images so that you can see a little bit more closely that relative blood volume. And the exciting thing for us is in research, if you can see a difference and then the numbers reflect that, that's really great. And then here's relative blood perfusion showing a similar trend. And so just to bring this all full circle, we also can get a 3D value for total vascularity of the colon. So I just want to go through what we did here. So this 3D pre-scan is taken before the microbubbles are injected. Then we go and record that 2-dimensional wash-in of those bubbles, the infiltration of those bubbles as I discussed, and we get this kinetic information about relative blood volume and relative perfusion. Then we go back after those bubbles have been circulating for a while and take a 3-dimensional post-scan after those bubbles have been circulating for a while. And then we can take this post-scan and subtract it from the pre-scan, and we can get a value for percent agent, and this is actually the total relative vascularity of that entire colon. And here's the values that we found for each of those small, moderate, and heavy tumor load colons that we discussed. And you can see that the small tumor load was 6.3%, the moderate tumor load was 18.9%, but at first, confusingly, the heavy tumor load is at 15.9%, lower than the moderate. And so we got to thinking about this, and then thinking about the stages of colorectal cancer. Remember, this is a very large tumor here. And so what we suspect and what we propose is that this technique is actually able to pick up that necrotic, potentially necrotic center of that stage 4 cancer tumor. So that just highlights, again, the resolution and the ability of this system to pick up these nuances that will be very important for detecting changes in these animals. All right, we're getting towards the end here. I'm talking much faster than I had planned. With any imaging modality, clearly there are artifacts and anatomical limitations. And so I just want to point out some things. This picture here in panel A shows sort of several things going on. So here's a tumor here. So this is the sagittal view of the colon. Here we can see some air bubbles in the gel, and they're kind of stuck on the back side of that tumor there. Again, you can remove those air bubbles by simply centrifuging your gel. And then this in yellow, with the yellow arrow, is a fecal matter. And what you can see is that it creates a very strong distal shadow below that feces. And so it's really clear and easy to know if that feces is in the way of your image. And actually what I did after this is, as I discussed, I then reintroduced ultrasound gel using the tubing into the colon, and I chased that feces around that flexure and out of the way of the image. And so there was a paper that discussed 2D ultrasound of colorectal cancer, and they mentioned that they couldn't tell the difference between feces and a tumor, and I argue that that's just not the case. At least in the diet that we fed our animals, this distal shadow was very obvious where it blocked ultrasound signal. Another way to assess that is if you have color Doppler on your system. So this tumor has vascularity and the feces does not. So it makes it very clear, a secondary way to assess. The only anatomical limitation that we really ran into, excuse me, was that in both male and female animals, the pelvic bridge and reproductive tract interfered with the signal. And so this was just very brief and for a few frames. And so I'm going to show you on this image here, or on that video again of the collection of the colon 3D. I'm going to point out when that happens. Hopefully, if it will play for me. Okay, so this is a male mouse. So there's the anus, it's really clear. And then you can see the penis show up here, and then you're going to see this distal blockage of signal for a little while. And then that signal will return, and you can start to see the colon again. So we calculated on average, we only lose about 15 to 30 frames of that total of a 344 that we were collecting. So that's really only about 1.5 to 3 millimeters of the total colon length. And in females, it was even less. So we proposed that this is not limiting. The amount lost is very similar in male and female animals, so we felt we could still compare them. And so we don't think that this is a too much of a limitation for this technique. Okay, with that, I want to give special thanks to Dr. Asvani for the encouragement and the use of his animals, and for listening to my crazy ideas and letting me give it a try. And also for I would like to thank Stephen Butters for answering my incessant questions. This technique is published in Molecular Therapy Methods in Clinical Development, which is an open access journal. So feel free to download that. There's a lot more details about the tricks and tips to be able to make this imaging modality work. And there's a link also at our core facilities website to that paper as well. And with that, I'll take any questions.
Thanks very much, Jessica. That was fantastic. Really nice description of a particular model, a technique, the details of working with that technique and that model, and generating some really nice data from that. So really appreciate that. I've got a few questions here for you.
Okay.
I'll sort of start from the get-go. I mean, are there any ideas why the incidence of colorectal cancer is going up in young people? Are there any indications about that?
Oh, and it's very new. I mean, that just popped up in the researcher that I work with, Dr. Asvani. I showed him that New York Times article, and so we're looking into that now. I'm sure it's been known for a while, but those of us that are working on colorectal cancer at least weren't real aware of it. So it's, lots of people have theories about diet, and maybe it's Western diet and so forth, but it's really interesting, especially that woman that I mentioned, Kristen. She was very healthy, ate a very good diet, exercised regularly, very active person, and it just hit her out of the blue. So yeah, it's really interesting though, isn't it?
Yeah, no,
what's going on.
Yeah, I was just sort of curious about that.
And scary.
Yeah, is there any kind of corollary in animal models for doing translational work? So, for instance, using
Yeah,
younger
we're
animals
thinking
versus
about
older
that.
ones?
We're not sure how to do that, you know, because it's not like when we're doing these colorectal cancer studies, we're not typically doing them in older mice to mimic the, you know, the aging situation when most of colorectal cancer happens. So maybe we already are sort of looking at it because we are doing younger animals, and maybe we're incidentally looking at a different, you know, a younger animal mechanism. I don't know.
Yeah, interesting.
Yeah.
Um, another question here, again, more sort of broad, but you know, you talked a lot about longitudinal imaging and that kind of thing, but I kind of want to get back to, you know, why is that so important? Why is the longitudinal imaging? Why does it matter? You know, and you did mention treatment windows, but why is this longitudinal aspect so
Right.
important?
So a lot of researchers just might do a study where they induce colorectal cancer and administer a treatment, and then they pick an endpoint, say 6 weeks out, and they don't check in between, right? So maybe we gave a therapy that improved for 2 weeks the colorectal cancer, and maybe it, for example, affected vascularity and that tumor down, but we didn't check them until 6 weeks, so we missed that happening at 2 weeks. And the metabolism of a mouse is so much faster, that 2 weeks might translate to a year in a patient. That's a big deal, right? So being able to catch, yeah, a treatment window, for example, is one really important aspect. And also to decrease animal use. So if we decide that we do need to look at something longitudinally and we don't have an imaging like this, an imaging ability like this, we would just have to use more ends, more animals, and euthanize more animals at multiple time points. And we, you know, we could follow the same animal from beginning to end without problem. So.
Okay, great. Yeah, that's very, very interesting. I think that is, you know, it's sort of a bit of a rhetorical question. I think it's, you know, understood why it's important, but it's just good to hear the details, especially in this particular model. You were also talking about statistical power, and I wanted to ask about that as well. You know, you're talking about rich data in order to get that statistical power. What exactly do you mean by that?
Well, we need quantitative data. So yes, we can get data at termination of how long the colon is and maybe 2D areas, but two-dimensional areas say nothing about the morphology of that tumor. It just says nothing about the attachment and invasion of that tumor or the vascularity of the tumor. What we found when we looked at the areas versus the volumes is we got somewhat different values, and a lot of these tumors, as you could see on that, for example, that persistence video that I showed, that tumor is almost mushroom shaped. So from the surface it might look very large, but maybe the stem of it is quite small, for example. So if we can get more data, you know, about the volume versus the area, I think that's primarily the most important thing, because it tells us so much more about that, that tumor. And you know, using some of the other imaging, like say colonoscopy, for example, you're seeing that tumor in 2 dimensions from the inside of the colon, but you're not seeing the total tumor load. So we need to know, so a patient has, you know, multiple tumors, for example. We don't care what one tumor is doing. We want that patient to improve. We want that whole animal, in this case, to improve with treatment. And we can't assess that if we're looking at an individual tumor and what it's doing, or looking at that tumor superficially just by looking at the area of that tumor rather than the volume. Does that make sense?
Yeah, gotcha. Thank you. You know, thank you. A couple more questions here coming in. There's a couple of questions about the kind of bubbles you're using. So they're asking, are you using a different kind of bubble, or are they different than the Vivo micromarker?
I'm not real familiar with the two of them. I can, or with the difference between the two in terms of chemical structure or whatever. They appear to be very, very similar. They have similar size, similar ability to enhance contrast of ultrasound. The difference the main difference from the VisualSonic ones that I'm aware of is that these bubbles do not come lyophilized or shelf stable. They come ready to use, and you need to use them within 1 month. And so you have to kind of time your experiments to be able to make that cost effective. And so yeah, that's the main difference that I know. But the company, there's a link on the, well, I'm sorry, I don't have a link to it, but if you look in the paper, there's information about that company out of Colorado. And basically, I think it's just a small lab that's developed some microbubbles, and they've had them tested and so forth and are selling them. So I think it was a research lab that studies nanotechnology that developed them. So.
Okay, great, thanks. There's a question here coming in asking, can this method determine the size of necrosis or apoptosis in larger tumors?
I don't know beyond, for example, in that large tumor that I showed that I proposed was necrotic. If you were to draw a region of interest around that, then you could evaluate the vascularity of that tumor itself. So perhaps you could compare that way. Remember, these tumors are pretty small. So I know that we can somewhat determine necrosis in xenograft tumors, for example. You can actually see a difference in the anatomy. So I've thought about trying to find a way to quantify that to see if, you know, those tumors, those xenografts are quite a bit larger, but we could maybe define a region of interest in the interior and compare that to the outer portions of the tumors. I'm not sure whether the resolution would be sufficient for this model because these colons or these tumors and colons for that matter are quite small, but we could certainly give that a try. I think that would be a really great application if we could take some of these larger tumors and find that out. I have not tried that. I haven't tried to manipulate the software to see if we could look at that specifically, but that's a great idea.
Yeah, and speaking from my experience as well, because we have seen other tumor models where people are interested in necrosis and apoptosis, and you know, those really are two different things. And I would say necrosis, you know, one good way of doing it is actually using the microbubbles to see perfusion. So in these, you're obviously the necrotic areas are not going to be perfused, so that's sort of one way to do it.
Right. Like what we found out with the 3D total tumor changes.
Yeah.
When we did the 3D, yeah.
Yeah, exactly. Another way, you know, there are molecular targets for doing apoptosis. Yep. We've worked with them a little bit, and you know, using other techniques such as photoacoustic imaging as well can sort of get into some of those areas which are you know, a little bit more sort of nuanced.
Right. Which, by the way, these bubbles can be tagged with a target like, say, VEGF, and so you could, in theory, have that target an area of, you know, necrosis, or, you know, or, well, not with VEGF, but you know what I'm saying, like, use it to target an apoptotic marker, for example. Right,
yeah. I mean, the challenge also is just getting contrast agents into a necrotic region, which, you know, by its very nature is not perfused. So there's challenges there as well. There are a few more questions here, and it's actually kind of good that you finished slightly early, because it's I always like to have lots of time for questions. We've got a few coming in. So people, someone's asking about any tricks about injecting the gel. How do you ensure sort of an even and uniform injection? If you're looking at the colon wall, like looking at inflammation, how do you ensure that you're not, you know, inflating it too much so that you're compressing it, those kinds of things?
Yeah, and some of that is a little bit just a practice thing. So as I stated, we use a 10 milliliter syringe, and then we're putting a 20 gauge needle on it and then threading it with like a piece of polyethylene tubing. And I'm actually introducing that almost all the way up to that flexure and putting gentle and even pressure so that some of the gel is actually coming out of that tubing, and I'm backing that syringe out simultaneously. So yeah, you can actually watch on the ultrasound. You can see it happening. So I practiced quite a few animals first and figured out basically how much pressure to do without like protruding and we don't want to blow up the colon, right? So definitely it's sort of a practice thing, but looking at the image and verifying that you're not, overextending that colon while you're doing it was probably the best thing for me. The other thing is we've got that flexure and then that upper part of the colon, the proximal colon, that we're not imaging. And if you pushed in excess gel, it would just kind of go up and around that flexure. And so I didn't ever have any problems, like we never had any ruptures or anything like that. And if you put too much in, it just comes out the anal end. By the way, without the atropine gel, or once the atropine, I'm sorry, not the atropine gel, once the atropine wears off, all of that gel just expels, even before the animal's awake, it just comes out with peristalsis. And that's why the atropine was so critical, is we couldn't get the gel to stay in the colon, right, so that we could image well. So yeah, we just found it to be, so to bring your question full circle, we just found it sort of to be a practice thing about how much pressure to do, but we didn't have any trouble with distension or anything like that we felt was altering the data, for example.
Okay, okay. Does atropine affect the vascular function? For example, would it affect any of the, the perfusion of the tumors, do you think?
Good question. And I don't know if I still have control of the image or of the PowerPoint if I change. So I made a slide showing changes in heart rate in mice prior and post atropine, and we got a slight increase in heart rate, but it was not statistically significant, and this was over approximately 100 animals. So we feel that the atropine is, can you see that slide? Is it still up?
Yep.
Okay, so we just felt that the atropine was not affecting, was unlikely to be affecting peripheral vascular function if we only had a change of 25 beats per minute in the heart rate.
Okay. Yeah, and as you mentioned, there's no way that's significant difference there too. So, yeah.
Right.
So another question. Sorry, I'm just trying to read it here. A question about variability. So for the model itself and the measurement, they're asking how reproducible is it? So for instance, if you did the measurement again a day later, would you get the same measurements, or even hours later, I guess? And this is both regarding the size and the contrast measurements.
Well, in terms of, I guess I would look at that is it repeatable when it's being measured by the user? So remember, we have to define that colon wall and those tumors manually. So what I've done is I've gone back and remeasured the same colon, and my data is very, very similar each time. So I'm proposing that it's very consistent, but I have not done a study, if you will, where I handed the data to someone else and they look to see what they get. So is that kind of what the person was asking?
I think so. I think it's just a matter of, a question about reproducibility. And I see what you're saying about, the user has got to do the segmentation. So, and I think that, you made it clear that, having the gel, being able to see, the contrast between the lumen and the wall and the tumor, I would say that's probably the most critical part. If you can see, right. I mean, you can see even, even I can see where the tumors are there. I don't think it's that hard. So I wouldn't expect there would be big differences in variability. I was just sort of asking if you had done that.
So, and the other place where there could be variability is with the vascular data. And so one thing, when you're pushing the bubbles, you need to be pushing them at the same rate. And I did that manually in this study, but reviewers of the paper suggested that we do use a syringe pump so that we're pushing those bubbles at the same rate in every animal, because kinetics is important, right? We're using that to determine that slope and plateau for relative blood volume and relative blood perfusion. So I would suggest that perhaps we need to use a syringe pump to give a consistent delivery of those bubbles. And then volume of the bubbles is very important. And that's actually something that we're thinking about right now, because we're trying this for brain imaging as well. Do I need to alter the volume of bubbles that I'm delivering based on body weight of the animal? In this study, their body weights were all very similar. These are all animals experiencing colorectal cancer, so their body weights were quite low. But when you've got an animal that, say, is, maybe you're comparing young and old, for example, you've got animals that are 30 grams of body weight as a young animal, but then there could be up to 60 grams in an aging model. So do I need to change the volume of those bubbles? So that would be another way, another instance where variability might come into play that I just wanted to mention.
Okay, great. Two separate questions here asking how long does this take per mouse, this whole procedure?
The whole process, if you want to do, so we typically would do a 3D reconstruction with the higher resolution probe. Then we would go back and do the lower resolution probe because nonlinear contrast needs to be done with a lower frequency probe to be able to get that type of data, that kinetics data. And so we would typically do the 3D reconstruction again with the nonlinear contrast running, do that 2D infiltration, that wash in, record that, and then do the 3D post scan. And we could do all of that in under 15 minutes typically. So completely reasonable. And it took us typically about a half an hour for the whole procedure because if you were administering microbubbles, because remember we did that surgical implantation of a catheter into the jugular to make sure we had patent access, but if you're good at tail vein injections or can figure out how to make that injection in the eye work well, yeah, you could be 15 to 20 minutes including prep of the animal. So this is not, it's not, the animal's not under too long, they're not getting too much anesthesia. We didn't lose a single animal from this procedure, and we did approximately 100 animals.
Oh, wow. Okay, great, great. There's your statistical power we were talking about earlier, 100 animals. That's great. Let's see. There's a couple more, and then I think we'll leave it there. Someone's asking about can we use this method for small intestine, for example, in APC colon cancer models with tumors in the small intestine?
Yeah, we wondered about that ourselves. Here's the issue. We can see really well the colon because we're introducing that ultrasound gel retrograde. I don't know how to get it up that high into the small intestine to give us that contrast of the lumen and walls versus the rest of the abdomen. If we could figure out some way to deliver something either orally that would enhance that contrast, but then again to be able to accomplish that without interfering with intestinal permeability and goofing up the animal in general, I don't know how to do that. So if we tried to do it retrograde, right, what's going to happen is all of that ultrasound gel, like say we've retrograde introduced more of it up and around that flexure, it's just going to pool in the cecum. I don't think it's going to be able to get backwards any further very well without potentially rupturing. So I'm not sure. It would be awesome if we could figure out some sort of way to contrast that small intestine as well, because we have an APC min model as well, and we would love to be able to see what's going on with those tumors higher up, but I don't know.
Do you think by administering the atropine and just looking with the intestine, sort of after fasting and all this stuff, do you think you'd be able, without doing the lumen injection, do you think you'd be able to see differences?
It's just so much in there, right? So you've got just miles of colon or intestine wound around. I don't know. I've played around with it trying to see. When we had the APC min model, I tried to use ultrasound to identify tumors, and it's just so much in there. And even with fasting, it's really difficult to get all of that food out. So even with fasting, we usually had on average probably 2 or 3 fecal pellets that we needed to flush out. So if there's fecal matter, there's probably a lot of matter in the small colon as well, or small intestine as well. So I don't know how to get all of that out and not harm the animal, I guess.
Okay. Okay. What about you mentioned in the beginning, you know, this is a fairly high throughput technique, especially if you were just doing volumes. I imagine you could do this pretty quickly.
Oh yeah.
What about the learning curve? So if you're training somebody how to do this?
I haven't had any trouble. Even people that aren't terribly familiar with ultrasound, they seem to be catching on just fine. As a wide perspective, I think this is easier to learn than echocardiograms. To get it right and to be repeatable, I think it takes less training than echocardiograms. So
And
that gives perspective.
then you're speaking from experience here. You've done lots of both.
Yeah.
Yeah. Okay.
Yeah. And trained lots of people.
Okay. Okay. No, that's good to know. I think we're going to leave it there. We're kind of out of time, but listen, I'd really like to say thanks so much for walking us through that, and thanks for answering all the questions so thoroughly too. That was nice to have that extra time. I'm just going to give a really quick announcement. I think Kathy here is going to give us back the presenter rights here so you can see our screen. But AACR is coming up, so the American Association for Cancer Research annual meeting is coming up. It's in Washington, D.C. From April 2nd to 5th. And we're going to be... Sorry, I just lost... 1317, sorry, my screen just went blank for a second. 1317, so please come on and see us and check us out. We're going to have something that Jessica didn't cover here, but we're going to have our photoacoustic imaging system there, which we just launched about a month ago. So this is, if you haven't heard of photoacoustic imaging or don't know about it or what kind of extra data it can provide, please come by and see us. You can also just get in touch with us, reach out to us at our website. That's www.visualsonics.com. We've got lots of resources there. We have a brand new website, so if you have, for those of you who are familiar with us, if you haven't visited us lately, please do. A lot of new information, a lot of extra resources. There's a lot of publications, including these featured publications where we, show a publication and then sort of summarize it in a quick way. And I believe, Jessica, your publication on this colorectal cancer model is there. You can register for our webinars there and check us out on social media as well. So again, thanks everybody for taking the time to attend. Thanks again, Jessica, for a great talk, and we'll see you at the next webinar.